So good morning. My name is Kendra. I'm an occupational therapist.
And I'm Toni Vitale, but let me be clear, she really is the brains behind this, all right?
OT power. Okay.
Yeah.
ALS is an illness that is often associated with loss of function, independence, and control. It challenges patients, caregivers, and healthcare providers. It's an illness that forces adaptation, sometimes on a daily basis. For a patient with ALS, driving is an IADL that is among the earliest functional activities that requires attention. It is a very delicate issue to address. Over the last six years in addressing driving with the patients followed in our clinic, we asked them to define what driving meant for them. The answers included a resounding freedom and independence, but answers also included going to work, visiting an adult child in foster care, going to the library, getting a loved one an ice cap, taking a child to soccer practice. These answers demonstrate themes of caregiving, productivity, and quality of life. When first addressing driving with a patient, I start by asking, do you drive? When the answer is yes, my immediate follow-up question is, when is the last time you drove? Because it's not uncommon for a patient to say 1, 2 years ago. While the patient has likely retired from driving, there remains that important connection to the activity. That photo ID, even if expired, represents an important component of their identity and self-worth.
So as Kendra just mentioned, many of the patients do drive in clinic. It's a delicate issue to discuss, and finding where it fits in with all the other information that we're discussing with them can be challenging. Prior to the implementation of this project, we found that we did not have a standardized approach to discuss driving with patients. And we found that the cessation of driving was different for each patient, sometimes detrimental to their mental health or to that of their caregiver. We also found that patients were not consistently advising the driving authority of their new diagnosis, that patients were underusing provincial car adaptation programs to prolong driving. And lastly, that patients were not reporting in clinic changes in their ability to drive, any recent accidents or traffic violations. And when driving was addressed in clinic, the conversation was usually led by the neurologist and/or the occupational therapist. If an evaluation was required, there were delays to access public sector on-road evaluations varying from 3 to 12 months. In turning to the literature for guidance, we found there was very little published. About 2% of articles on driving took into consideration people with ALS. And it was very difficult to identify any clear thresholds for when initial and repeat on-road evaluations need to be done. So with all this in mind, our goal was to create a standardized approach for driving evaluation for all patients that were driving in clinic. The approach had to respect the provincial body guidelines. It had to involve the multidisciplinary team. It had to be quick and easy to administer in clinic. And we had to establish guidelines of when patients need to be referred for on-road evaluations and adaptations. So the beauty and strength of the clinic is really the multidisciplinary team, each of us using our own expertise to provide patients with input. The concept of the steering wheel as a visual representation for the Driving Quality Improvement Project resulted from a brainstorming session and made perfect sense in light of the subject matter. But more importantly, as we also saw in all the other presentations this morning, I was really, always moved and touched. It's really the patient that sits, or the person with ALS that sits in the center of the steering wheel, surrounded by the members of the team. Our goal was to address driving in a client-centered manner, which allowed the patient to be the decision maker, respected, informed, valued, and empowered. Each of us has a role to play.
So the ALS Steering Wheel is a tool that we developed and implemented in our clinic. It addresses areas that include medical, physical, cognitive, functional, and socio-spiritual components. These areas take into account the complexities of the ALS diagnosis and are in keeping with our Canadian and provincial guidelines. Many of the physical and cognitive tests that we used were from a tool called the GRIMPS, And this tool was used in a driving study in the US in 1998 to identify at-risk drivers. It was the Maryland Pilot Older Driving Study. From this study, 6 out of 9 of their tests in the GRIMPs were identified as having predictive value for patients at risk for crash. And they provided 2 types of cut points, a prevention and an intervention. When an intervention cut point was reached, this indicated that further investigation, like an on-road, was needed. For the ALS steering wheel, we took 7 tests from the GRIMPs. We added a medication review, a questionnaire, the ALS FRS, the MRC dyspnea scale, grip strength, and the ALS CBS. As you can see on the worksheet, you see the different team members that are able to perform the test, as well as identified prevention and intervention cut points. Once a patient attained 2 prevention cut points or 1 intervention cut point, we strongly considered proceeding with an on-road evaluation.
So since 2018, the research grant from ALS Canada has funded over 48 driving evaluations. The funds were used to cover a private on-road evaluation with an occupational therapist and a driving monitor. Since the patients have the professional evaluations required, they can then tap into provincial programs for car adaptations to prolonged driving. Patients can also access driving lessons to learn how to drive with the new adaptations if needed. Without the private on-road evaluations and a 3 to 12-month waiting list for a public on-road, patients were rarely able to use the services of the provincial adaptation program. So we have complete data on 48 evaluations. Of those 48, 12 patients passed, 30 passed with conditions, and 6 failed. From Kendra's presentation of the tool, it's important to remember that the minute once a patient met 2 cut points for prevention or 1 cut point for intervention, an on-road evaluation was recommended. The most common intervention cut points which led to an on-road evaluation were hand grips, foot tap, and arm reach. It's possible that some patients actually met 2 cut points. With regards to the ALS FRS-R scores, ranges were similar in all categories, so it was not necessarily a good predictor of driving ability. And with regards to the recommendations for those patients that passed with conditions, the evaluator recommended that the patient can only drive a vehicle with an automatic transmission, power brakes, and power steering. In addition to these recommendations, some of the minor adaptations recommended were spinner knobs, convex mirrors, and extended secondary controls. Major adaptations that were recommended were switching accelerator and brake control to hand controls, and an adapted steering which required reduced effort. It is interesting to note that the technology in new cars, such as a push-button start and power wipers, have actually had a positive impact on prolonging driving in patients with ALS. So for the tool, I think we could say it was fairly easily integrated into our clinical practice. It is very complete. It can be administered in whole or in parts. For example, if 1 or more intervention cut point was met and an on-road was indicated, we did not necessarily administer the entire battery. Conversely, if after completing the entire battery, if there were no red flags and no cut points, we did not recommend further evaluations. Additions to the tool could be an exertion scale for patients to self-assess their fatigue level during the entire driving activity, as well as mindfulness exercises to prepare and facilitate for the eventual retirement from driving. We had 1 patient that had passed an on-road and had adaptations identified. Due to a lengthy approval process, a repeat on-road was requested. By this time, the patient had significantly physically deteriorated and was struggling with not pursuing the reassessment and was visibly saddened by the situation. As a way to help the patient, I presented a mindfulness exercise, naming 1 negative aspect of being a passenger and 2 positives. So the negative aspect was the loss of a cherished activity. The first positive was being able to coach their partner to improve their driving skill as passenger. The second one was being thankful to be alive each time arriving at a destination
with their partner driving. The moment was magic, the tears became laughter, and in that moment we saw the patient pivot. In addition to the tool, a right AFO, there seems to be a consensus among OTs in the rehab centers that needs to be evaluated because it needs to potentially become a condition on the permit. So for that reason, the wearing of a right AFO in driving should be an added intervention cut point. The involvement of the multi-D team was certainly challenged in COVID, and since we implemented this, we've seen several staff changes. We definitely did expand involvement from beyond the doctor and the OT to increase implication from the nurse, the speech therapist, and the administrative agent. One special accomplishment for our speech therapist was ALS Quebec, allowing them to provide the patients that drove and had speech changes quicker access to that diagnosis card for their wallet. So as Toni mentioned, we used our funds from ALS Canada to subsidize private OT evaluations. The use of the private OT allowed for quick access to on-roads. The average delay was 2 weeks, whereas in our rehab centers, it's anywhere from 3 to 18 months. The private OT was able to start the process for government-funded adaptations. We had quick and consistent and rapid access to the driving evaluation reports, which really helped expand our understanding of the driving process and the adaptations possible. One limitation we did encounter is when patients needed an on-road with an already adapted vehicle, that needed to go through the rehab stream. The other thing that we came to realize is the private OT was wonderful, but their involvement was finite. So once the evaluation was done, the file was essentially closed.
So since the implementation of the project, we have been able to address driving in a systematic manner with all patients that come to clinic. We've been able to tap into provincial adaptations program to prolong driving. We've also raised awareness with the community partners regarding prioritizing evaluations for people with ALS regarding driving. As a result of this new sensitization, the community partners were willing to share their resources to accommodate areas where longer wait times occurred, allowing the person with ALS to go outside of their region of care to get a timely evaluation. Most of the community partners were rehabilitation centers, and they already had very clear, short mandates for programs with people with ALS, resulting in a closure of file at the end of the program. So this is no longer the case. The rehab center will now keep the file of the person with ALS open and is aware that as the illness progresses, that the patient may return for a driving evaluation at a later date.
So recommendations to the field. I think it's really important that the healthcare providers have a clear understanding of what their local driving guidelines are, understanding their role in counseling and evaluating patients, knowing also the resources that are available with delays and costs, and knowing alternate methods of transportation that exist. The approach needs to be systematic and consistent, and this is absolutely facilitated by multi-D involvement. It's important that driving be addressed early, closely monitored, smooth process, and ensure a safety net. Also, the driving authority needs to have a clear and systematic approach to managing patients with ALS and driving in collaboration with the healthcare providers involved. The implementation of the steering wheel with the generous support of ALS Canada was a positive experience for our patients, families, and our team. We were able to attain our primary goal of prolonging and promoting driving safety. We were able to provide patients with a sense of function, independence, and control. And now we have a short video. So there's a spinner knob on the wheel, and the patient is actually with their right hand controlling gas brake. You're missing a swear word here because the poor patient was cut off. So you see the ramp up, there's a swivel seat. And this patient has had adaptations for driving since 2016, 2017. And this is a recent video. Patient is driving with AFOs, and you have the spinner knob on the wheel, which allows for one-handed driving, and it also facilitates turning. So in wrapping up, there are a couple of special thank yous. Christiana Salmon, who's here today, who is the driving force with us in this endeavor. A special thank you to Norma Kaisik and our other patient, Jean-Roch Mathieu, that were our superstars in the movie videos, our doctors, our team, the private OT that helped us with the evaluations, and of course the local rehab centers. Thank you.
Thank you. Thank you, Kendra and Toni. Are there any questions? In the front here.
Sarah McGuire from ALS Canada. One of the clients that I work with had the dual diagnosis of ALS and FTD. His ALS symptoms were very minimal, so it was largely the FTD that was the problem. And as we know, it doesn't necessarily manifest in some of the ways that a general cognitive test might catch. He was able to tell me lots of things. His memory was fine, but he could no longer understand road signs. So when I'm thinking about the cognitive piece, is it general or is it focused on some of the elements of FTD?
Well, I think it's something, the tool that we use is the ABS, the CBS, as well as the Trail Making B. And those are looking at executive function, attention, working memory. When there's issues with that, that's what we use as a screening tool to bring them to the on-road. In a patient with cognitive difficulties, as per the Canadian medical guidelines, moderate to severe cognitive impairment is contraindicated to driving. So the screening tools are a depistage. It's a way to start. But if they're very, very cognitively impaired, they should maybe not be driving. That being said, the gold standard for any road test, for driving, is a road test. It's the best way to assess them. They put them in the situations with the left turns, with the driving signs. They do the highway. They do everything to really see how they're able to manage cognitively.
Okay, thank you.
Hello, Linda Levine. I'm caregiver to the amazing David Busek. And we have a van like Norm's, etc. I just love what you've done because this is a conversation David and I have had about how will we know when he's no longer safe. So that's amazing. And I just wanted to add to the conversation, when people are asking me away from David how he's doing, the second question is, can he still drive? So you addressed what it means to him, but it means something to the general public who knew nothing about ALS. Driving seems to really tell them something, and I have no idea what that is.
I mean, I think that ALS patients in our clinic will probably tell you they're the most evaluated patients for driving in the world. But no, I mean, I think there's no way of knowing, but I think there is a sense. We have the patients that want to pursue it. If they want to pursue it, we put them to the test and see if they're able to do it. I think a general sense is there's a natural retirement to driving. There comes a point when the patients no longer feel safe, and I think that's probably how most of them do retire, naturally.
But I think we should share what the literature did tell us is that neurologists and spouses will often overestimate the capacity to drive, but adult children will usually be good judges.
Yeah.
We're ending here, but I don't know if David wants to say something back to his wife.
No, I wouldn't publicly say anything back to her. But your last comment makes me glad we don't have adult children. I really have two questions. One is if you have a good source for purchasing adaptive equipment like spinner knobs and spinner knobs in particular. I imagine a hand controls you'd have to go through some sort of formal agency, but for the spinner knobs or other lower level things like that, are there good resources you've found? And the other question is about my biggest concern with driving right now is the ability to get in and out of the vehicle quickly if I need to in an emergency situation. And I wonder if you have anything to say about that.
Okay, so for the first one, the access to the adaptations was done through our private OT. I do believe Norm could add, but I think it's Savaria. There's somewhere on the West Island that deal with all of that. In terms of getting in and out of the car, that is something that is part of the OT evaluation when they're assessing the on-road. So there are bars that might be able to be almost like a grab bar to help in and out. There are those things that could be added and are definitely looked at.
All right, this is obviously a very interesting and filled with a lot of different levels of anxiety and questions, but we need to move on. But thank you so much for providing us with this presentation today.